Welcome to the Hernia Gods Podcast. This is your mere mortal host, Luke Elms. The views, thoughts, and opinions expressed on this podcast belong solely to the hosts and guests and do not necessarily reflect the official policy, position, or opinions of Orlando Health or any of our employers. And now, without further ado, let's talk hernias. All right. Welcome to the Hernia Gods Podcast. This is your mere mortal host, Luke Elms. I am joined today by Vedra Augenstein, the current president of the American Hernia Society. We are so honored that you have decided to join us, and welcome.
Thank you so much, Luke. I'm so honored to be invited in this very, very cool podcast. So I recently heard about it, and then when I got my invitation, I was very excited. Didn't know what to expect, but I still don't know what to expect. But Thank you so much for picking me.
Well, this is a podcast about hernia surgeons, not hernia surgery necessarily, but we're so excited to get to know more about you. As we were talking before, one of my first interactions or my first getting to hear you speak at length about more of your personal side was at the American Hernia Society this year for your president's address, where you talked a little bit about your childhood, and I was just intrigued with such a very unique experience. And so I would love to just hear a little bit about you and about who you are.
Yeah, no, thank you so much, Luke. So as you've alluded to it in my speech, I talked a little bit about things that maybe a lot of people didn't know where I was. I think everybody can hear my accent, but they don't really know exactly where it's from. So I actually was born in Sarajevo, Bosnia, and I grew up there. And I actually moved to the U.S. when I was 11 with my brother just to learn some English and stay with our cousins. And then we kind of got stuck because the war broke out in Bosnia, and our parents were stuck over there. We were stuck over here. So we, just started studying and kind of going through the motions and waiting for them to, come and join us 3 years later. And I stayed in Louisville for 20 years. I did my undergrad there. I did my med school, and I did my residency at the University of Louisville. Then came to Carolinas Medical Center for a 1-year fellowship in minimally invasive surgery. Never thought hernias were going to be anything, even when I was interviewing, I didn't really think I was going to be doing hernias. I thought I was just going to be doing MIS surgery, but landed in Charlotte, the hernia mecca, for years. And then, and since then, really, it's just been my practice now. It's pretty much all I do.
So whenever, I think that people's practices many times take those turns that they're not expecting. Whenever you got into your fellowship itself, was hernia something that you were drawn to, or was it just something that you felt like you were really good at, and like the referral patterns and where you were? Is that something that you think if you had done a training at another minimally invasive fellowship, is hernia something that really spoke to you, or was it just kind of the circumstance it's something you've grown to love?
Yeah, I think honestly more like a circumstance because of the kind of cases that we were seeing at Carolinas. It's one of those things that it seems like a big challenge, and I think we all like challenges. But then when somebody shows you how to break it down into like a very easy problem, and then you repeat that same kind of solution so many times, then you're like, hey, I know how to do this, so it kind of you get to be decent at something that is considered to be difficult, and it kind of becomes a little bit easier at that point, which in residence you really don't know what you're good at, and you're just kind of trying to be proficient in everything that you're doing. And I really didn't think, minimally invasive surgery. I still felt like I really went to MIS fellowship for 2 procedures. I wanted to know how to do a lap colon and a lap inguinal hernia, because we did not do a whole lot of laparoscopy in Louisville. It was very trauma, vascular, and surg-onc heavy. So a lot of open cases. Appies, gallbladders, we did those. But I thought if I'm just going to do general surgery out in practice, I got to know how to do a lap colon and a lap inguinal. And, little by little, we started doing some of these big ab wall cases. And then I was actually in Texas for a year in private practice and left that and came back to Carolinas. So that was kind of a small, about 10 months there, and then came back to Carolinas. And I've really enjoyed that pathology, the hernias, the really big hernias. And, that's kind of been I think we all like a challenge, and that's kind of what it's felt like. So, and it still does.
Yeah,
So,
yeah, it's definitely a humbling field. I think when you went to Texas, was that just a broad based general surgery practice that you had kind of entered there?
yeah, yeah, it was a very, very busy private practice. Very few private practices out there, I think. And my husband at the time and I were both looking for a place to settle because he's a plastic surgeon, and we wanted to find a spot where, we would both be happy. And we kind of interviewed, and that seemed to be a good spot to be. And then basically, different job offers came because he was a year because his fellowship was a year longer. So, and then we decided that we would come back to Charlotte. But it was I had some really good partners, excellent surgeons, some of them MIS trained, some of them not. And it was just incredible to see how good they were
Mhm.
laparoscopically, even without a fellowship. Because I came down thinking like, oh, I trained at Carolinas, I look at my lap skills, and then humbled within the first few cases going like, wow, they didn't even do a fellowship. So it was
Yeah.
pretty cool, but it's just a very hard working group of people. I mean, it's just private practice surgery.
Yeah, surgery is such an interesting field because you can have really big names that are extremely skilled, and then you can have people in the community that nobody has heard of outside of 20 miles from where they practice, and they are just kicking butt and taking names, and they're just
Absolutely.
fantastic surgeons. And so, it is like I said, it's really an interesting thing where, even it's all about reps and proficiency
Yeah.
I think that it's funny you talked about really wanting to feel like you knew how to do a lap inguinal hernia. I was so terrified of inguinal hernias when I first came into practice because I was like, this is such terrible. Like I felt like I never had a good grip of the anatomy through my training baseline, and then you're going into these hernias and I don't know what it was like when you went into Texas, but right as I came out of my training, I wasn't getting the straightforward stuff. I was getting the stuff that nobody else wanted to do, and
No,
it's humbling.
100%. In Texas, I did them all open because
Hmm.
none of my partners, they did like, lab bypasses, they did Nissens, all this stuff, but inguinals, everybody did open. So, and
Hmm.
I felt even after my full fellowship at Carolinas, because we do a lot of big cases, we do inguinals, but I still felt like I wanted to make sure I had backup. Like, what if I get into a tough one?
Yeah.
And I just don't have anybody to call. I worked in, several different hospitals, but I don't want to be in that situation where I don't have anybody. So I did everything open. And I kind of felt bad. Like I was like, man, I can't believe, like, even
Yeah.
after a full fellowship. So when I came back to Carolinas, I just would park myself in the OR and watch Dr. Henford and Dr. Kircher were my mentors. And I just watched them torture the fellows, I mean, not torture,
Hmm.
but like,
Yeah.
it's so much nicer when somebody else is in the hot seat and you're just kind of watching. And
Oh
all
yeah.
of a sudden I'm getting the planes. I'm like, oh, I get this now. So
Yes.
and now it's like my favorite case to do. So one of them anyway.
Yeah, it has turned. I don't know if it's just my personality that I really go after things that I feel like I'm not good at, and it bothers me,
Right.
and so I end up like hyper focusing on getting comfortable doing something like that. But now, doing robotic inguinals and open inguinals, those are like what I do the most. So I've ended up having like a pretty large inguinoscrotal practice, which, those are always.
Oh yeah.
you,
So good stuff.
you say you're literally praying to the hernia gods. You're like, I hope that this reduces in the OR because if it doesn't, we're in a whole other ballgame. So
No, exactly, exactly.
yeah.
They can, and that's what I mean. Dr. Kircher would always say because he's one of these amazing MIS surgeons who does all these solid organ surgeries. I always
Mhm.
call him a laparoscopic vascular surgeon because like he doesn't lose a drop of blood and he's doing these adrenals and stuff. But he used to say like I could do an adrenal before I could do an inguinal hernia. That's how difficult that case is. And
Mhm.
everybody expects for it to go perfectly, but the
Yeah.
anatomy is really difficult. Every
Yeah.
single one of them. When I teach my residents, just that sac where it is, the tissue on it, you get a little bit of blood in the field, you can't see anything.
Oh, yeah.
It's
I tell that's my biggest thing with the residents. I'm like, because most people, they get in and they're tearing and tearing, and I was like, if you're doing a complex inguinal hernia, the second you get blood on the planes, your case is extended but by a long time, and it's so much more difficult. I was
Yeah.
like, there's a reason I'm so anal retentive about how much bleeding I have in these cases, and it's one of the reasons I like, for me, the robotic approach. It's funny because we have something in common. I came out of my training, and I joined a surgeon who was in his mid 70s, was very skilled at what he did, but he did all open surgery. In fact, when I joined him back in 2015, he was still doing open appendectomies, and so
Okay.
he was, yeah. So that was kind of the way that lent itself. And like you said, you want backup,
Mhm.
because if you ever get into a bad thing, I felt it was for some reason it felt more of a failure to me to it felt like more of a failure to me to have that convert from a laparoscopic case to open, because the person I had to call for help was not able to do laparoscopic, than it would have been just to call somebody in during an open case. And I also felt like I needed to be really comfortable doing open surgery. So I went out and I did pretty much all open surgery for my hernias for the first couple of years. And it wasn't really until my younger partner, who was a year behind me in training and came and joined, he jumped into the minimally invasive stuff head first. And so we just complement each other well. So he kind of drugged me kicking and screaming into that. And then now that's like all I do. But
But
it's
that's
um
great
it's interesting.
sometimes, and it's your personality. Like, some of
Mhm.
us, I don't know, like I would personally have a really hard time recovering from like an iliac injury or a bladder injury,
Yeah.
just like thinking about how do you even explain that,
Right.
like, because anything can happen, but
Sure.
like, so, and that's a case, like, you usually have like young people, I mean, healthy people, like a
Yeah.
lot of times those surgical planes don't have any kind of mesh or anything, if you're doing them kind of first, not recurrent or anything like that, so it should work perfectly. So for
Right.
somebody that's supposed to be an outpatient procedure, and then you have massive
Yeah.
blood loss or something like that, that's, I don't know. That would be really hard, and I think we don't talk about the effect on the surgeon for complications like that. But as you know, I mean, you are surrounded by structures that just in open anatomy, you really don't have those kind of risks. I mean, unless you're in a really long place. So,
Right. Yeah. I mean, I agree. There's that. One of the things about the open surgeries that always made me a little bit more concerned is the wound morbidity. I was always,
yeah,
again, it's like a mesh infection, just feels like it shouldn't happen.
yeah,
And so even if you get into a situation where you may have one, you're just going like, oh my gosh, like, is this? And because, like you've alluded to, for me, I think everybody handles complications differently, but complications in elective surgery are devastating.
yeah,
And and, it, and it's something that people don't really understand. I think that some of the residents that see our practice, I'm pretty much purely elective now. Our practice, everybody wants to get to that, right? They're like, oh, we
yeah,
love the ability to schedule your day and to kind of pick the cases you want to do and go after these more aggressive cases. And I'm like, sure, that's all amazing. I said, but you got to understand that there, at least in my mind, there's like zero room for failure,
yeah.
and the patients expect perfection every time.
Mhm.
The patients have an expectation in the elective surgery game, at least in this market, whether you think it's right or not. It's a service industry,
Yeah.
and you better be on your game. And so there's no like, you know if I did nothing, they were going to die, and I did something and saved them, and it may not have gone perfectly, but at least I intervened. It's, I took this person that had this symptomatic inguinal hernia but was not like bedbound, and they have an issue, and so it can be really devastating. Now, when you do your surgeries now, um, do you have because as you get to places like the Carolinas, I'm sure there is so much complexity and so much volume of that complexity. Do you feel like you further narrow your hernia practice down into more specific types of hernias?
Yeah, I mean, honestly, like our wait time now, I mean, I'm hearing we're scheduling in May and June for me. And honestly, I told my schedulers and my nurse, so I stopped doing gallbladders because there are a lot of surgeons every general surgeon in our institution can do a gallbladder. And I'd hate for them to have to wait 5, 6 months for scheduling.
Yeah.
And even like the small umbilicals, primary inguinals, I'm like, that's really, not a good use of my consultation and things like that. So
Right.
I've kind of, put myself in this block where I'm like, I just want to see the disasters and things like
Yeah.
that, because I feel like that's where I can make the most difference. But they're not, the easiest cases, because those patients, even though they're elective, they can end up in the ICU. It's a lot of loss of domain. It's a lot of fistula. It's a lot of
Right.
infected meshes. And, you do anywhere from 4 to 7 to 8 of those a week, and then they're all in the
Yeah.
hospital over the weekend, and you're
Sure.
worried about everything. So it is a lot, but I still feel like if I feel like it's fine. I think that's where I need to be. And
Do you feel like did you feel like you left? Do you feel like it hit you in a general surgeon way when you decided you were giving up gallbladders?
yeah,
Did it hit you?
it did for sure. And then I gave up esophageal hernias as well, and that was like my favorite case in fellowship. And
Mhm.
but I ended up just seeing, like, I was just see the type fours, the redos, and I'm like, I'm never seeing like a normal. I've never seen a person who has like a 2 centimeter hiatal hernia in like 10 years. So
Mhm.
it became a practice where I was just like, this is not even fun anymore. So I was like, I'm going to give up the Paris. But the gallbladder, and I just a few weeks ago, I had somebody just randomly show up, and she has a gallbladder. And I'm like, well, I really haven't done one of those in a couple of years, but I mean, I can, and
Yeah.
it's very strange. Like it felt really hard giving those away. And I know a lot of like hernia surgeons who just do ab wall, like
Mhm.
he's been doing just ab wall for years. And I talk to
Mhm.
them and I'm like, man, so that's all you do? And that's where I'm getting to. But I do feel bad kind of, letting go of that. So
Yeah, that microcosm. So now, like, uh, it's so interesting to look at. Well, first of all, you talk about a case with all downside, no upside. It's a gallbladder. Like, you ever have a complication with a gallbladder? People are like, you can't do a gallbladder. You're like, it was really hard. They're like, sure, but
yeah, and
but I think that
one of
there's
my
so much.
colleagues, yeah, one of
Look,
my colleagues is a surgeon, but she went through the office, or her OB was referring her, and then she texts me. She's like, "Your office told me you don't do umbilical hernias. Is that true?" And I'm like, "I'll do your umbilical hernia.
yeah,
Don't worry. I
make
think
an
I
exception.
can do that." But that's
Yeah.
yeah, it's kind of like, okay, we can do those too. So
Do
I
you
do
feel
miss
like
that a little bit.
when you talk about the complications and how that can be very difficult, I mean,
Yeah,
the cases you're doing them at a rate that complications, even in the best of hands,
yeah,
are happening probably not that infrequently. Not saying that you have
yeah.
like abnormally high complication rates, but just
Right.
to say that, like, when you're taking care of, you start looking like the complications from the loss of domain and the fistula
Yeah,
cases.
for sure.
People accept that, like, for instance, a Whipple is going to have a complication rate at a certain rate, and they're like, that's really high risk surgery, blah blah blah. But sometimes I think there's a little bit of a disconnect, at least outside of the field of hernia surgery specifically, as to how difficult and how high stakes some of these more complex abdominal wall reconstructions can be compared to the public perception.
Yeah, no, you're absolutely right. And in 15 years, I've had two patient deaths. They're both loss of domain hernias, very kind of similar pathology. And it's just, there's just not much written about these loss of domain hernias, and we just don't have a good way of quantifying, the amount of stuff that's outside, the amount of stuff in, the compliance of the abdominal wall. We really don't have any calculations. But I'll tell you, I mean, you don't talk to a lot of patients about, like, you could potentially die from the surgery,
Yeah,
unless you're trying to say, you probably shouldn't have, you
right,
shouldn't have this done. Like, you're on a bunch of oxygen, you're trying to convince people because you're like, you're alive now. You should take that. You're winning right now
right.
because this is a big surgery, and
Yeah.
so when I'm telling you probably shouldn't have it done, you probably shouldn't. And most surgeons, I think, in general. But those two are tough because elective surgery, you don't see that, and I
Mhm,
have partners who see patients die all the time because they're doing like trauma, acute care. And,
mhm.
a lot of times just having those patients survive is a huge win because you do
Sure.
some amazing procedure, they live and all that. But for us, something like that, like you said, it's really just not expected, you
It
know?
just hits different. And like, I one of the first things that I kind of have given up, I still do it every now and then, but I don't pursue it aggressively, is like colon surgery. And for me, colon surgery drove me crazy because every time I did an anastomosis that did an LAR and did the anastomosis or something, I would like this 14-day clock would start in my head. And I don't know why 14 days. I know it could happen after, but
Yeah.
for me, it was always like the leak countdown. And so for that 14 days, the patient's in the hospital and they the nurse happens to check their vitals after they've been doing like jumping jacks in the room. They're like, their heart rate's 110. And I'm like, oh my God, they're leaking. And I'm like, you're in
No,
there.
I have the same level of like anxiety about these things. And,
Yeah.
and I guess, if you're a colorectal surgeon and every one of your patients is that, then it's not as bad. But like in hernias, we do fairly few anastomoses. So that's definitely raises that awareness, and you're worrying about it all the time. I don't know. Everybody's a little bit different, but it sounds like we
Sure.
have very similar personality
Yeah.
with that
Do you,
anxiety.
do you feel like, similar to what you were saying about the colorectal surgeons, do you feel like as you've just narrowed yourself down into these very, very complex surgeries, do you feel like, not that you don't care, that's not what I'm saying, but do you feel like you become a little bit more resilient in the fact that you do get these, like, you have a certain set, like you have a history, like that you're capable, just at least logically. Sometimes it may not feel that way, but you like know that you're capable, but then when you have those complications, it's easier to weather those as you move forward in your career, or is that something that still hits you the same as it did day one?
I think, that's a really good point. And I think I try, all of our fellows and residents, when I talk to them, I always tell them, you got to have a really good denominators of successes. So the few complications are kind of more diluted, because if you go out and practice and you're going to be handed not the most easy cases, because
Mhm.
you're new, and you're going to be working in all the worst cases. So you got to be really careful and selective. And I think a lot of times we're like trying to people please, and, oh, I'll just take that case. I'll take care
Yeah.
of it. I've seen that in fellowship. And then you get a few complications right off the bat. It's really hard, I think, as a young surgeon to show up again and have that confidence. And I think that's why, like surgical mentors, having partners that are actually going to be there. I mean, everybody says, oh, yeah, we'll take care of you. But, when it comes down to it, you got to have people that are really going to think through these things. Even when you have a complication, sit you down and be like, hey, this is how I would have done it. This is what we're going to do. This is what you need to do. And
Yeah.
just explaining that kind of stuff. And hopefully they're, in residency, you learn a lot of that, but it's a little different when you're on your own, and, it's really kind of, you don't have a attending standing above you and taking the,
Yeah.
yeah, yeah.
And some of these, you come into some of your practices and it's a little bit dog eat dog out there, right? I mean, it's a business. If
Yeah,
you're coming into there are certain,
they don't,
some,
yeah.
yeah,
They're
they don't
high
have time. They
help.
may be your competitor, at
Yeah.
some level.
For sure, for sure. Yeah, I mean, and that's the hard thing, I think, to decipher for everybody as they're trying. And I always try to mentor the people going out into fellowships. Like, do you really feel like you're going to have somebody that you're comfortable talking to and having, help you through this? Because you don't want, especially if you're somebody who really gets anxiety about complications and things like that, that can end your career if you don't have
Yeah.
good mentorship. You have a few complications, it can really be bad. And it's not fair, because, we should have that. I mean, we learn so much, like general surgery residency has gotten so we just the amount of pathology that we're seeing. You got robots, you got different tools, staplers.
Mhm.
Like there's just so much that you have to learn in those 5 years, and then you have work hour restrictions. So now the time that you have to learn those, it's much quicker, and then you're out there and you're supposed to do it all and be totally independent, and then you get hired by people that need you. They don't have time to help you, maybe.
Right.
That's unfair, and I think we
Yeah.
need to be better mentoring and giving back.
Well, it's interesting because a lot of these jobs, they don't have the ability to hire somebody in and not be, they don't have the ability to hire somebody from a financial cost analysis aspect until they have like the house is on fire, and then they bring in somebody to help. And then you're throwing these people into these high stakes environments. There's not like that ramp up period. There's a fine line between being busy enough to get your reps in to feel confident, but then also being like overworked or under supported. And so I think that it's an interesting thing. I know that we've done a lot from the point of view of like the large committees and things for mentorship in general, but it just seems like we could probably do even more on the microcosm. Because another thing is there's a whole host of surgeons out there that are just not realistically involved in the societies. Like it's
Yeah.
just not something that they participate in. I mean, like I said, this was the first year I went to AHS. I've done a decent amount of hernias. For if you looked across the, I do quite a few hernias in a year compared to a lot of people I suspect, but definitely not the highest volume.
No.
But I think that it's an interesting thing that we don't really have a lot of that mentorship. I don't think is being done at the ground level where a lot of these people are struggling.
Yeah, I mean, I think it's because our society, we're tying our compensation to volume and not quality, and
Yeah,
that's the biggest problem. So these surgeons who are out in practice for 10, 15 years, who could be great educators, are just not being compensated to be teaching anybody. If you're
correct.
running and you're trying to take care of your cases and you don't have time and that insurance is not paying you to be an assistant or is I mean, it's just not fair. Like, I
Mhm.
really think as a society, we have to have a better system. That surgeon, these first 5 years, whenever they need an assistant, they should be able to have an assistant that's going to get enough compensation to come in there and be a real assistant. Because
Mhm.
otherwise, it's just not going to happen. And the young surgeons are going to struggle. The old surgeons are not going to have the time to do it.
Yeah.
So that productivity quality, I mean, it's something interesting, but I think it's in hospitals' interest and in our, I think American College of Surgeons, instead of this being just some like, oh, mentorship is a great thing. We all know it's a great thing, but let's have some action around this. Let's
Sure.
let's pay the older surgeons to mentor. Let's
Mhm.
because if it's just being done on goodwill, obviously it's not being done.
Yeah, it's an interesting thing even, calling for help even when you're an attending. There's
Yeah,
such a difference between having a partner show up and do the case versus having a partner show up and help you do the case.
right.
Because there's a lot of I've experienced both through the course of my career where people have shown up and been like, "Hey, no, 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 make this move," and you're like, "Oh, that okay, now I get it." And the next time you don't need them. And then there's something completely different with saying, "Hey, I'm in a really bad this and that." They come in and they're like push you off the sticks and they
Yeah.
finish it up, and you're like, "Well, I don't know exactly what that would have helped." I mean, that learning curve that you go through in residency, it's not like it stops as soon as you graduate.
No, not
Yeah,
at all. Not at all. I mean, and it's honestly like in a lot of these cases, I mean, I will still run out and talk to one of my partners, make a phone call, whatever it
yeah,
takes. But it is hard if you don't have people you feel comfortable calling. It is hard if you feel like, especially you're young, maybe you didn't get the exposure, maybe you're doing cases that you're not comfortable with, and now you feel like you're bothering your partners, and
yeah.
they're not getting paid to help you,
Mhm.
and it's just I think it happens, and it's unfortunate, and then in the end, your outcomes are not going to be as good, and it's like this perfect cycle of just that it needs to be fixed, it needs to be yeah, in my case. I think
It's
I don't know how
tough.
to fix it.
I don't either. I know the problem exists, and the fix is I don't know that truthfully, I'm not sure that it's fixable with the current system, just system wide. I'm not saying one individual institution, nothing like that. I'm just saying that with the current way, with reimbursements and things, I don't know how you can make it really work without a significant investment of something. But I mean, you got people that are coming out when you're calling your partners. Like you said, sometimes you feel like a burden for
Yeah,
calling them. I felt like a burden a ton early in my career when I would call for help. It destroys, in many cases, it can destroy your reputation if you're brand new to a hospital. Like, oh, this person called for help. This guy's calling for help all the time. He doesn't know what he's doing. And a lot of times, the people determining your reputation aren't other surgeons. That's the really hard part is the people determining your reputation many times are the opinions of maybe the anesthesia team or the OR staff or the administration. And some of those people, maybe it's not, maybe they mean well, but it can really have an effect on you. And it's also really poorly understood what you're doing. Whenever I hear people talk about, oh, so and so does an inguinal hernia, He did his inguinal hernia in 20 minutes. And I'm like, I mean, it was a primary inguinal that you could only feel with coughing.
Yeah. Yeah.
Great.
Yeah.
I was doing a
Right.
redo inguinal scrotal, Yeah.
It's
So I'm,
just 6 RVUs, no matter which one it is, right?
oh man. Yeah. That's a whole other brutal
That's a whole
thing.
other issue. But think about it. Like, look, we always compare ourselves to the airline industry, or even like builders. They're building this humongous condo building right next to mine, and I'm just looking at the amount of supervisors that are there all day long, making sure this thing goes off perfectly.
Right.
The pilot who's flying the plane with his co-pilot, they're probably both making a salary, right? I mean, yeah, it's maybe probably a one person job, but like everybody realizes that it's important to have two people in there
Yes.
because of all the passengers. So I don't understand why, there's not such safeguards where, we realize they're young surgeons, they need mentorship. If they're in there, they're going to be better surgeons. You're not going to be stressing out your partner while they're in the middle of a case, dragging them in there. There's just got to be, it's got to be safer, otherwise,
Yeah.
because we have no way of measuring quality. That's the main thing. Nobody is talking about. They just say, oh well, maybe it was a tough case. Maybe that's why this happened.
And realistically, the days of having a video of your surgery, or something like that, those are, becoming much more common now. But historically, like you're trying to relive a complication in your head from a surgery that may have happened, 10 surgeries ago. It's not like we have the ability when I was doing like an open inguinal and it recurred. I can't like go back and be like, well, what
Yeah.
stitch was it that failed? Where did I make the mistake here? It's just really hard in some cases to learn from your mistakes early on. And that is, I think, the most troubling aspect of a lot of complications for me is when I get done with the case, there is a complication. I have to weather the mental storm because for me, it's very difficult.
Mhm.
I have to weather that mental storm and then get to the end and go, I don't know what I would have done different. Like to me, I'm always like hyper aware of like the next time I do the case, oh my gosh, am I going to make the same mistake again? But I'm not even really sure what I did that caused this, and
Exactly.
you can end up in this kind of spiral. And so in those cases, I've had a lot of very supportive people in my career. I really take it a lot in that have been able to come in cases like that where I'll just call my partner on the phone and say, I just need another set of eyes. I'm pretty certain what I'm seeing is correct, but we talk about inguinal hernias. We make all these statistical analyses about, well, this should be there. And so if that is what I think it is, then this should be this. You're going
Yeah.
and it's all that observer bias that you can end up down this like pathway of like, holy crap, I misidentified the first thing and the whole case went awry. And so you call people in for stuff like that, and you really hope that you have supportive people around you, because
Yeah.
if you don't, it can be very, very difficult.
And what's your threshold of comfort calling other people in? So we have a really busy HPB service, and I've done a lot of bad gallbladders. Thank knock on wood, I've never cut a bile duct or injured it. But my threshold was, I would struggle. But if I get into trouble, I'm always going to be like, you know what? I give up. I'm going to call them. I would much rather they come in here and take a look and give me a little bit of support, and I'll get it done, rather than calling them and being like, hey, guess what? I just injured a bile duct, so it's coming on your service.
Sure. Oh yeah.
That's not, it's not a luxury that everybody has. You could be working in a small hospital where there's like, 4 ORs and you don't have that. But,
Yeah.
The ability for people to feel comfortable to say, hey, I just don't feel comfortable proceeding. I don't know that it's something that we instill in our trainees. And I think it's everybody's level of comfort, just depending on what kind of person you are. I would never go bungee jumping. I'm terrified of sharks. I've got a lot of fears, and one of them is cutting the bile ducts. So
Yeah.
but some people love all that stuff. I don't know if it correlates perfectly, but who knows?
Yeah, I'll never go scuba diving to a shipwreck. For some reason, like shipwrecks scare the crap out of it's like an illogical thing. I don't know. I'm totally happy. I'm not totally happy, but I'm comfortable in situations where I can hear audible bleeding. But but a shipwreck under the sea, and I'm just like, nope, not me.
Oh, exactly.
But I wanted to get back just a little bit to some of the discussion you had at your president's address.
Yeah.
First of all, I guess whenever you enter into a role like being the current president of the American Hernia Society, how does that hit you whenever you like hear that? Is that something that you feel like, not trying to make you be overly arrogant or anything, but is that something that you felt like you were building towards, or is that still something that you wake up sometimes and go like, man, that is kind of like pinch me? Because for me, I
Yeah,
think I would just end up in a situation where I'm just like, how did I end up here? Like this doesn't mesh with my
100%.
mental makeup.
Yeah, no, I'm very much like you personality wise. I'm still like, I still don't recognize it when I see my name and it says that. I'm like, what? No, that there's no way, It's,
Mhm.
I've told, I think in my presidential or in my Nia Swans Award address, I talked about, I was in practice for 7 years before I had like a first podium lecture at AHS. So, I was already pretty darn busy, because I think a lot of people like come out of like fellowship and immediately are expecting all these invitations. And it's just, it's not always the case. Sometimes you really got to put some time in. But then, through like the education committee, I kind of worked my way to the board and things like that. So at that point, once I got nominated on that, on the executive board, I kind of knew it was going to happen. So it's like I've kind of lived with it for a few years, but it still is kind of weird and it's almost over. And I'm kind of like relieved, because I don't like any of that attention. It
Right.
comes with, I'm sure, like great responsibility.
Yeah.
That the main responsibility is also when, you're president elect and you're putting the meeting together. So once that's
Okay.
over, you kind of feel like, okay, I just hope there's no disasters during my presidency here to deal with. And then we'll say
Right.
it's a successful year. I would say it's super exciting to be part of AHS now because for all the years that I've been part of it, and even since fellowship, essentially, there's so many committees, there's so many great people really trying to make a difference. And I think as a field, we've grown so much, so there's just a lot of stuff to do, from education to advocacy to all these like hernia fellowships now. And it's a really cool time to just kind of see and absorb, because so many times I'm like, oh my gosh, I didn't even realize we were doing that,
Mhm.
and there are people like putting all this stuff together. So I would say anybody who's not involved, I mean, I think the membership is super cheap. It's like less than $200, I think. Um, but then you get access to the website, and there's a lot of like pre-recorded lectures, and we're constantly trying to make it better for every surgeon, even the busy private practice surgeon who doesn't have time to go to the meeting. We want them to be involved, because this is not like a fan club where it's like just we celebrate the few people who are like posting on IHC, which it's great to post on IHC, but I realize that there are thousands of busy, excellent surgeons and people
Sure.
who are constantly trying to get better, that are part of this crowd. We're all part of it, and we can learn from each other and get better. So it's an exciting time, but like you said, I'm like, pinch me. This doesn't, it's not real. So
Yeah, it's just sit in the audience and you listen to the people present, and it's just going like, man, that is insane. I don't know. I guess I was probably just in the audience like fanboying all the people presenting, going like, my goodness, I can't believe that you read the names on the papers, you hear the presentations, you hear the names talked about, and then you go and you actually see people in person, you realize that they are just like a human being. I don't know. It's like it's such a weird, intellectually you know it, but like seeing them in person and hearing them joke around with their friends, or seeing Dr. Hannaford get emotional and talking about the way that he's approached his career, or the tributes that we had at the meeting. Those types of things, those that just really sets into you that like it's bigger than the pathology that we treat. And the community that I think within the hernia community, I have not had exposure to the HPB community or the trauma community. I'm sure they have their own stuff, but it was just a really unique experience getting to go there and see it in person. Because the one thing I will say about the meeting is, despite there being such a wide variety of the types of practices, of the skill level of the surgeons, I mean, just being honest, of what people take care of, and the complexity with which they take care of, there was still a camaraderie that was felt even amongst the people that were not directly involved in the actual presentations at the meeting. I think that was something was really, really neat to experience, and kind of like endeared me to the community in general.
No, I mean, and I'll tell you, I kind of like grew up in that fellowship and around those people, but until I got that first invitation, and even then, I mean, I felt so much like an outsider. You know, you see all the cool kids talking to each other, hanging out, and you're just like, oh, I like hernias too. You know, join the club.
Yeah.
It's really like when you like actually just step in. The people are just like really nice, and like you see like David Chen, Conrad Balliser, you see that whole
Yeah.
group of people that are just so they're so generous with their time to help anybody and everybody. And I can't tell you how many times you see a surgeon sitting there showing them a CAT scan, going through it just to take care of patients. Like it's just beautiful. I mean, that people are doing that. I don't know if it's happening in other fields of medicine, law, business, whatever it is, but I don't know. I just really think the hernia family, and I include everybody who does hernias and wants to be part of this, part of that family, is a little bit different, and I think that's nobody should feel anxious about talking to anybody in this part of community. If you have questions, ask them, because you'll be surprised by how willing people are to donate their time and
Yeah.
expertise.
Yeah, I think, one of my some of that I think is lost in the internet sphere,
Yeah.
because of the feedback that you can get in a comment section can sometimes be a lot more brutal than they would ever say to you in person. And so,
Yeah.
and there's obviously, different personalities, and
Yeah.
we are surgeons at the end of the day. And but I think that it was a really unique experience. It was just really cool to see all that. Whenever you were giving your speech, you were talking a lot about your childhood, and how you kind of touched on at the beginning of this episode too. But you came over here, and when you came over was it with your sister? Is that right?
A brother, yeah.
Brother. You
A
came over
boy.
with your brother at the age of, was it 11 or 12 in that
11,
range?
yeah.
And you came over here, and you were coming to kind of get exposure to English and all those things.
Yeah.
How long were you planning on being here?
So it was actually our winter break, and we were staying with cousins who spoke Bosnian, but I don't know how we thought we were going to learn English because, it's a lot different here than it is in Bosnia. Like if you're in Sarajevo, you just go out in the street and you hang out with kids and you talk and you learn the language. We're in Louisville, we're living in a small community. There's no kids playing outside anywhere. So
Right.
we're literally sitting at home and you can watch TV maybe, but like there's no exposure to English. So our cousin said, "Well, why don't you guys just finish this like school year off? So we're just going to put you into schools, and you guys just finish the school year off, and then in June when it's summer, you guys go back." So we said, "Sure, let's do that." But then the war broke out in April, so we kind of got stuck in the middle of that school year. I mean, the political situation, like, I don't know, your buddy was very instrumental in what was going on in the war there, but it kind of started out with like Yugoslavia being the big country. And then Slovenia broke off, and that took a couple of days. Essentially, there was no fighting because you have Austria and all the Western countries around Slovenia. Then Croatia, there was a little bit more of a war, but then Bosnia is kind of like landlocked, and there's just, and they kind of, it was like a 3-year war, lots of casualties, and there was just no way to get out. It wasn't safe. We feared, like, we would hear of like this tunnel that they were making under the airport. You would hear horrible things about how people would try to escape and they run over the runway and they get shot by snipers. I mean, just like, and I'm sitting here not having heard from my parents for months and months, and I'm just like, I hope that they're not like so desperate to see us that they actually do something stupid like that, because we're fine here. We're gonna be fine, And I just took my son back to Bosnia this summer. Actually, that was his first time, and I was hanging out with my best friend growing up, and she actually she was a professional ballerina in Bosnia, and now she teaches ballet and all these things. But she was telling me how she would still during the war go to her ballet lessons. And it's probably about a 3-mile walk from where she lived to ballet. And she would literally like be sneaking next to buildings because I guess, that's the best way to hide from snipers. Like if you're in the middle of the street, they're more likely to hit you, And she's like
Mhm.
an 11-year-old every day going to her ballet lessons. And she says one time, I think the sirens were going off. So she knew that there was going to be a bomb. And
Mhm.
she remembers that her dad told her, don't run over fields. You got to stay next to buildings.
Right.
So she's walking next to this building and a grenade hits this, this like the hill and buries her essentially under. And she's like, I thought I died. I was covered, but I was still alive. And some lady digs her out, basically. I mean, she wasn't harmed, but, and that's my best friend. And I'm like, I'm just getting chills thinking about this,
Yeah.
But, the shock after I told her all the experiences we had with the transition, living with, people that we didn't know, even though they're family, we didn't really know them, learning a new language, it's just really hard from like economic, fitting in, not knowing if you're going to see your parents. When I told my friend all of that, she said, man, you should have just stayed in Sarajevo. It was way easier for us. At least we were all together. She's like, even
Yeah.
though she could have gotten like, killed by the grenade. She's like,
Sure.
yeah, sounds like you had it rougher than we did. So,
Yeah, isn't it wild? I mean, because I don't know, maybe I won't say maybe. My wife would definitely say I'm just a whiner, but the but the you know I think back on stuff from my childhood, and I'm just like, oh, that was horrible. Oh my gosh, this was so bad. And then you hear stories like yours or your stories like your friends, and you're just going, everything can be put in perspective, but it is such a how did that? Were you always driven, or do you think that type of atmosphere kind of had you just went into this had to do it kind of mode, that since you were just kind of thrust into this situation that you didn't really have an option? It wasn't like you got to choose, you just kind of had to learn on the fly. And I'm sure that in some ways those skills that you unfortunately had to learn at a pretty early age transitioned pretty well into the resilience that you've been able to develop throughout your career. But do you think that it changed you in a way that led to some of the current successes you have?
well, I think it definitely all kind of, you get skills in life that you never know you're going to need. And then you're like, a few years later, you're like, oh, I needed that skill. It's a good thing I went through all that,
Hmm.
horrible stuff because now I have that skill. I mean, I think growing up, my brother and I were really sheltered. Our parents, like, we did no chores. We had no curfew. We were just like the ultimate spoiled brats. I mean, we were good kids, but we never had any responsibilities. And then we came to our cousin's house and it was like totally different. And you just don't have that anymore. It's not mommy, putting the dishes in the sink, like, or doing any of this stuff. And even, they had a younger daughter. So, then I'm actually taking care of another child and I'm 11. Until then I was a child. So it's just all of a sudden the responsibility changed. It was like a, huge, like 180 degrees change. And
Yeah.
there was nobody to complain to. I went
Yeah.
from like being able to tell my mom and dad everything to now I have to pretend everything is perfect because I'm scared they're going to run over the runway and get killed. So
Sure.
I'm just like, school
Wow.
is great. We're getting A's. Oh, everything here is just perfect. We're so happy, where it's just like, you're living with anxiety. You don't know. I mean, you go from being the kid that I was organizing all these like not podcasts but like all these like singing competitions, like, oh, we had a lot of like cool things, and then you come to a class where everybody's like, oh, she must be stupid because she doesn't know any English. Like, I asked her something and she just looked at me. She totally didn't understand. I said, what's up? And she just looked up. She didn't know what I was saying. So
Right.
the slang, the like, and then having to, I literally would sit there with a little dictionary. Like, doing history homework was the worst because like you had to read like a whole page and answer questions, and
Mhm.
I would have to translate every other word pretty much, and then it didn't make any sense.
Oh
So
man.
it was just, there was nobody to teach you English. I mean, Bosnian's not a common, now we have so many resources, but back then I would like write my own dictionary because I'm like, I've looked this word up 5 times already. I need to memorize this thing. So
Mhm.
so it kind of, and at that point my brother and I were like, this is survival. We don't know if our parents are going to make it. who's going to pay for our college? Like, we heard college is expensive. It's free in Bosnia. It's expensive in the US. So like, nobody's going to pay for that. So we have to get
Mhm.
scholarships. We have to study. And it was a big transition. It was the real world. And I think those were kind of the most formative years. I mean, I tell my parents all the time, I'm like, oh, if I stayed in Bosnia, I would be some brat. I would have no job. I would still be living at home. This was the best experience in my life, actually, to be there and just kind of like get, and it's much like surgical residency. You go from being this med student to just like trial by fire, and then you walk out and you're like, man, I can crack a chest open in the ER. I can take a bullet out of,
Sure.
somebody's belly. It's very different. So.
Yeah. Do you think it informs you as a parent now? Your experience back then, has it changed how you
Yeah.
approach things?
Yeah, I definitely don't let him get away with like everything. I try to, of course, every time I tell him some of these stories, he's like, oh, it's like your parent telling you I walked uphill, both ways to school in 3 feet of snow. Like they just, kids these days, they have it so easy. And, not all kids, but like, I feel like most of my generation and friends, they're living, where I think the biggest problems they have to deal with is how much they're on their phone. We have social media issues. We have, anxiety. We have like toxicity in food. Like, those are issues that they're going to have to really struggle with,
Yeah.
where for me, it was a little bit different, but it's still, we're super lucky to be safe, and just and make it over here. So, and I talked about in my speech the girl that was one of my best friends in Bosnia that unfortunately, died during the war. And it was
Mhm.
just, it was horrible, very devastating to her family and all of us. But, so many kids lost their lives just, so.
Yeah, it's tough. I look back on some of the trials that I had when I was a kid, and everybody. The thing that I've come to learn through working through some of my own stuff is that, well, I'll give you this anecdote. When I was a third year resident, I was in the doctor's lounge, and I was sitting next to this attending, Mark Demers. I hope you listen to this at some point. He was a great surgeon. He's still in practice. He's a kind of a Renaissance man. Read heavily. He was a musician. He had his hobbies, and he was really well respected. And so I was sitting there, and my parents called me on the phone, and they were church musicians, in addition to everything else they did, but they were talking about the difficulties they were having trying to maintain the church choir, because not everybody felt as passionately about it as them. And so, and so there was people's lives, pull them away in 100 different directions. So people weren't showing up to the practice as much as my dad would have liked, and they were stressed about that. And they just talked to me, and I think I'd been on call and was like struggling with like an outcome from a patient that you kind of see some of those that stick with you for a while. And so I was sitting there talking to him, and I got off the phone, and I remember just being a little bit like, and Mark, Dr. Demers goes like, what's going on? And I go, well, I said, my parents are complaining about this or that. And I said, I got like real problems. And he stopped what he was doing. He looked at me, and he looked me right in the eyes, and he goes, Luke, to them, it's just as big. And I was just like, okay. It's like one of those moments when your ego is like, it's like goes back down, a little bit down to size. So I've learned that type of aspect about what people's struggles are. To them, that's all they know. So it's a really interesting thing. It's like it's hard as a human, and at least especially like a competitive human, like most of us are, to not like almost like trauma compare. But I know that growing up, through some of the stuff that was tough for me, it definitely affects how I relate, and some of the things that I deal with my kids. Like my brother, one time when I was 7 and my brother was 2, we were staying. We had some family staying with us, and they didn't realize that he didn't know how to eat around a plum, around the pit of a plum, and so they just gave him a plum, and he didn't know it, and he swallowed it, and he started choking. And I was the only person in the room with him, and I'm looking at him, and I don't even understand what's happening, but he's like literally turning cyanotic. And so finally, my mom comes in. She tries the back maneuver. She tries the Heimlich. Nothing works. And so she was a school teacher and she'd been trained on it. And, the thing you're not supposed to do is stick your fingers down somebody's throat. And she tried everything and finally was just like, and as he's like about to lose consciousness completely, and she stuck her finger down his throat and pulled it out. And
Wow.
so he turned out to be, fine and recovered from that. Was like, they didn't call the doctor or anything.
Yeah,
There
that's
wasn't a doctor around,
saved his
but
life.
yeah. Well, but like now when my kids, they like cough on a drink of water and I'm just like, are you okay? Like, is there anything?
It's the
Yeah.
same thing. So as a resident, we had a lady come in. She was very nicely dressed, all these rings. She was at one of the steakhouses in Louisville,
Mhm.
and she basically choked on a piece of steak. And
Mhm.
she was still alive, but she was brain dead by the time she came. I
Mhm.
mean, it was the worst story. So every time my son is eating steak, I tell him about the lady that died. So I'm always like, do I need to talk to your steak? So even with his friends, they were here and they were eating some steak, and he's like, "Oh, my mom's going to tell you the story about a patient of hers."
Yeah. Yeah. It's like when my wife she like feeds our kids grapes and she's like puts them on their plate and like take them off, cut them into like 8 pieces, like puts them back on. But yeah, no, it's so funny. We were in residency and we were all sitting in the doctor's lounge and I was sitting there with one of my co-interns and he ended up doing orthopedic. He was a preliminary. So he's sitting there and we're all sitting around the table and all of a sudden his eyes get big and he realizes that he's choking. And so we're all sitting there and he's like, and he gets up out of the table full of surgical residents and runs across the doctor's lounge to the table full of the internal medicine residents. And it's like, and the internal medicine residents get up and like give him the Heimlich and everybody's like relieved he's fine. And then he comes back over and we're like, what the hell, man? You went to the internal medicine docs to get it?
He didn't want one of you guys to pull your knife out of your pocket.
You didn't trust us? Come on. He was a thin guy. It would have been a pretty easy trach. I'm just saying, it would have been pretty easy. But
he made that split-second decision. He wanted medical, not surgical management.
Yeah, he was like non-operative management, please. Yeah. No, I think it's just all that to say it's, what you went through is so like dramatic compared to what the majority of us have ever experienced. It's just really interesting talking to you, hearing how the perspective you have is only from that. And so, I don't know that it probably doesn't register with you nearly as much about how incredible your journey has been. But yeah, no, that's something that I think that a lot of people would have probably withered from, but you've managed to kind of like harness that and that perseverance that you've had has been pretty impressive.
Well, I really appreciate it. I don't know. I mean, I always wonder, like, how, your parents get you to do certain things. And like, I think my parents were really good about scaring me about stuff. So I try to do as much of that with my kid. And then he's just like, Mama, less yappuccino, please. And I'm just like,
Yeah.
but I'm gonna tell you one more thing, one more fear. Let me just unload it off you. So it's like total like parenting by fear. And I hate it. I just like, but that's, they say it's like your heart walking outside of your body, that those are your
Yeah.
children, and you're just so scared that something will happen. So you're trying to instill that in them, but yeah, it's just really, I think parenting is just very difficult, and it's hard for me not to keep giving advice,
Sure. Yeah. But I do think that as I've worked through my growth as a parent, just as it's all trial and error, and you kind of have your ways that you're like, I don't want to mess my kid up that way, and like you're like focused on this, and like over here you're like messing them up in 20 other ways that are completely novel, but but
Yeah, probably telling them too much, and I mean, I read about these things all the time about parenting, and all these kids that now kids are like they don't go anywhere by themselves, So I'm like telling my son to go to the grocery store, which is like right across the street. I'm gonna go by yourself, and then I'm like looking out the window,
oh sure.
texting him, "Are you okay? Are you okay?"
Yeah, I'm on the Google Home cameras, like watching like every move. Like, it was funny that
Find my like
yeah,
exactly.
I let them cross the street. My kids, I have an 8-year-old son and a 2-year-old,
Okay,
I have a 5-year-old daughter, eight
okay,
and 5. And so they were crossing the street um, going over to see our neighbors who you made reference to earlier. Our neighbor who was the lead war crimes prosecutor for the Bosnian War Crimes Tribunal, but they were going across the street to see them, and I'm like Tucker's 8. He's like, Dad, I know how to get across the street. I'm like, you look both ways, and blah, blah, blah. So they go out, and I see Tucker, and he looks both ways and goes. My 5-year-old daughter, like literally as she's running across the street, she's like turning her head looking, and I'm like running out the door. I'm just like, get over here. Like, you don't get to go over there anymore. I told you to look. Yeah. So it's, it's always the hyper aware. It only took me a few pediatric surgery rotation trauma calls before I was just like, okay, well, this is a whole other level of fear that's been unlocked and all these phobias. But
you see all these injuries that you're like, I do not understand how this could have happened. So you tell kids, and I'm always saying, "Oh, don't go on the monkey bars. Don't do this. Don't get next to the lawnmower." Just all the little things. But I think like that translates also into like teaching surgery residents. Because I love to like tell them all the different complications, everything you've ever seen. Well, let me tell you about this. Let me tell you about that. And some of that I think storytelling is helpful, because who knows, maybe they're going to have a similar case, and at least I think you're kind of showing them humility, because rather than being like, oh, I'm this great attending, nothing bad ever happens, or I know how to handle it, you're kind of leveling with them and like, let me tell you all my mistakes, so then you don't make them.
Yeah, no, I think I think that level of humility is something that I didn't pick up on enough whenever I was a trainee. I'm sure it was probably there. I just didn't it just didn't register with me, or at least the people that I was really trying to emulate didn't really show their outward, they didn't show their uncertainties the same way I was feeling. And so then whenever I went out and I felt uncertain, then it was like this whole like, oh my gosh, I must just be a bad surgeon, because all the people I like looked up to, they never showed me any of that. And so I think that like what I was getting to, you hit on perfectly, which is as I became a parent, went through those phases of becoming a parent, I think I became a better teacher. Just because of the self-awareness that I kind of started to develop as a parent, it translates easily into just relating to other people that you're maybe trying to mentor or bring through their own journey that you've passed through already.
And the residents are a lot more receptive than children. Just wait till you're a teenager.
Yeah. No, there's nobody can destroy your confidence like a child. So
that's very true. It's a humbling experience all the time, but yeah, the residents will listen a lot better. But it's important, and I think maybe it's a generational thing too. I hope that we're getting better about talking about problems, complications, uncertainties, showing the human side. Because I grew up in Louisville. I was the only female in our residency class, and it's a very much kind of I don't want to say just a boys' club, but it's like kind of an old school residency where you just were there to work, and you couldn't whine and complain, and and I think things have changed a little bit, because I can see our residency program, there's so much more emphasis on mental health, all these different things that I think are super important, and
I think that you look at some of the ways that we used to do it before, and I interviewed at a couple of programs that openly talked about their divorce rate, and stuff like that. And I'm not, to each their own, but in some of those cases, that was not necessarily what I was looking for. I was couples matching at the time too. And so, those types of situations, I don't ascribe to the idea that it requires it to be a toxic environment for it to be an environment that can generate a proficiency. I understand it's going to be hard, and I think that there is some benefit to, obviously, if the first time you've ever been up for 24 hours is the first time you take a 24-hour call as an attending, you're probably going to struggle. There's a little bit of a learning curve to that, but I think that the idea that everybody has to it has to be like prescribed suffering just to become through this. I don't know that that's absolutely as necessary as some people might think.
I agree. And, everybody's threshold of pain and suffering is different. That's why, I don't know where I saw, but somebody said, just remember that person you're talking to, that may be the worst day of their life.
Mhm.
And, like it could be the nurse in your OR, it could be your scrub tech, it could be one of your residents. You just don't know what's going on. And, and I know we're busy. I know we're like rushing. I know we have a lot of responsibility, especially when you have that patient, in your hands, depending on you doing a good job. It's really it's hard to like have that patience, but trying to just kind of remember that with your
Mhm.
trainees and everybody else, because it's just we don't know the reality of that. And I think we need to be better and have more of a cushion in our lifestyle to actually process and be better people. I always feel bad, sometimes when we're rushing through a case and maybe I didn't get to teach as much, or maybe I hurried the resident up too much, because you got clinic starting, you got this, you don't want the patient to be under anesthesia an extra hour. So you're just kind of trying to move things along. And then I go back and I'm like laying in bed and thinking about it. And I'm like,
Yeah.
man, maybe that was too rough. Maybe I should have like said this or that. Like I really kind of question myself, and I hate that, but
Yeah. As my practice has gotten busier and teaching has become more sparse, and just out of necessity, and it is something that I resent. Like I resent the fact that I am
right.
always feeling like I'm being pulled in two different directions, because like you said, you have to put in the time to really give them the experience and the learning aspect. But then on the flip side, there are also other people that are relying on you. And like in your clinic, you're such a super specialist. There's only really a few people in the world that do what you do. And so, it's not like those people in your clinic are going to see somebody for, removal of a sebaceous cyst, that there's many, many people that could take care of that. It's a very different situation. And so the pressures that you end up under, trying to balance your own practice, trying to balance the productivity expectations of the job, and trying to balance teaching and mentoring in a way that is compassionate and effective. I think it can be very difficult. And sometimes I find that to be some of the hardest part of the job, is trying to find that balance.
Absolutely. And then you take that balance home and you have to do that with your family and
Hmm.
your kids. And, they
Yeah.
all understand, even when you're not on call, that you're still, actively managing your patients and things
Mhm.
like that. So it is challenging. And I think, I hope that people who are not in the medical field or maybe are in different fields understand kind of the stressors of that. I don't think any of us are superhuman when we decide we want to do surgery. Like, I mean, it's not, and you don't necessarily need to be that, but there are a lot of stressors. I mean, I think it's just different levels. Misdiagnosing a patient, having something technically go wrong.
Mhm.
Uh, it definitely can wear on you. So.
Absolutely. Well, I super appreciate your time, and I appreciate you coming on. It's been a fantastic talk. One thing that we do at the end of every episode is I give people an opportunity to do their hernia hot take, which is essentially you get to express your opinion on something around hernia surgery. Sometimes it's an unpopular opinion, or your kind of prediction for the future, just kind of your parting thoughts on hernia surgery in general. So, no, there's no right or wrong answer, but this is your opportunity for your hernia hot take.
Well, I think where hernias are going, I think we're definitely doing more extraperitoneal repairs. I think in general, like surgical training, I mean, obviously, closing the fascia is important, but I think we are placing meshes into much different positions than we were in the past. And I think even in, going away from the retrorectus space, except in some cases, as you know, we do a lot of preperitoneal repairs. I think we're going to see more of that. I think we're going to see more initiatives like, what's core health? Well, is it healthy to be cutting all those muscles? And we don't have really good tools to tell us if it's okay or if it's not okay, because, you're comparing a patient with a gigantic hernia to a patient who now doesn't have a hernia, has a huge mesh, but maybe their transverse abdominis muscles are cut. Was that necessary? So I think a lot of like, my robotic practice is mostly all preperitoneal. I don't do a lot of TARS. I don't do a lot of retrorectus except in very, very few cases. So that's kind of my prediction. I hope that, I think people need to collect their data, present it, and go to hernia courses and just, hopefully this is going to be a really exciting field for many more years to come. A lot of surgery is going away, but hernia surgery is here to stay. I think you're seeing like, bariatrics is definitely taking a hit. I think transplant oncology, there will be a lot of cool medicines coming out in the future, probably that are going to eliminate some of the surgeries. But I feel like hernias are there to stay as long as we have laparotomies and surgical incisions for anything. It's a really cool, for all the young surgeons out there. I think it's something to kind of invest some time in and learn how to do these things.
Yeah, and umbilical cords. As long as we have umbilical cords, we can always fall back to the simple umbilical.
That's cool. We're going to be busy.
Well, I sure appreciate your time. Sincerely, I know that it's hard to come and dedicate time to have these types of discussions after the long day at work and balancing all the family balance like we've been talking about. But we sure appreciate you coming on, and hopefully have you on again sometime in the future.
Well, Luke, I really appreciate your time in doing this. I mean, this is a phenomenal idea, very original, and I really hope that your time is well worth it. I think you really enjoyed these conversations, and I hope you meet a lot of surgeons, and I hope at some point that this becomes very, very popular and you get a lot of sponsors, and then you're going to have to decide if you just want to do this versus you want to actually do surgery.
I think that's what my wife is scared of. She's like, you eventually went through all this, and now you're just going to be a full-time podcaster. That's her. First, it was a full-time musician, and now she's worried about podcasting. I don't think she never really gets a break.
Maybe you'll do surgery, music, and podcasts.
Hey, that'd be just fine with me. So, well, we sure appreciate your time again. Thank you so much for coming on. With that, we'll wrap up another episode of the Hernia Gods Podcast. I'm your memorable host, Luke, signing off. Thank you so much.
Thank you.